Welcome back. And we're moving into our first conversation for this morning as we talk about a program that we are trying to build, I should say, as a partnership between the health and education sectors, and it's being coordinated through PAHO. We have with us on set to tell us more about it Dr. Sonja Caffe, who's the Regional Adolescent Health Advisor for PAHO Washington. We have Dr. Stanley Kutcher, who is a professor of psychiatry at Dalhousie University. And on the end, we have Dr. Claudina Cayetano, Regional Advisor for Mental Health, PAHO Washington. Good morning and welcome.
Thank you.
More lovely to be here.
Thank you.
And how are we doing this morning?
I'm doing good. I can't speak for these people.
Very good.
Good in health and mental health?
Yes. Happy to be in Belize.
This is such an important conversation that we're having, and I know that there are so many different aspects that needs to be addressed. I want to start off by understanding how the partnership was built to bring the process of establishing this program in Belize.
Okay, thank you. Thank you, Marlene. It's so good to be here with you again. When you ask how are we doing, I want to say mentally I'm feeling well, not so well physically, but it's good to be here with you all. So in terms of this partnership, so the Pan American Health Organization, as you are aware, is the UN agency that specializes in public health. My role at the organization, I work with the mental health program, but we're very fortunate that we also collaborate with each other. So my department is non-communicable diseases and mental health, and my colleague, Dr. Caffe, she's from another department, so she's the advisor of health. So together, we join to be able to to work on this project for adolescent mental health. And importantly is that because with PAHO, previous years, we have had a we have something that we call collaborating centers, which are nominated by WHO as Center for Excellency to support the work that PAHO is doing. So this is how we started to get to know Dr. Kutcher as part of this collaboration from the University of Dalhousie. So they have a program on school mental health literacy. So the idea is to bring that to Belize and to work with two ministries, the Ministry of Education and Ministry of Health. The idea here is that we want to be able to work with the teachers for mental health literacy. As you know, most kids spend their time adolescent at school, and a lot of these teachers need to learn to understand and know more or less how to deal with this. But this is why we're here. This is to introduce that project for Belize.
Now, in putting together any project and getting the funding and support that is necessary, you need to have a clear analysis of the problem. Mm-hmm. And that's what I want us to understand. What are some of the challenges that we've identified in Belize that we feel a program like this will help us with?
And it's not a challenge only in Belize, and I think it would be good to hear from my other colleagues too, because it's not a challenge only in Belize. Mm-hmm. It's a challenge that we find worldwide. Mm-hmm. So it's a challenge that needs to be tackled, especially because this is a population that is one of the biggest population, and I'm sure my colleague Dr. Caffe will talk to you about that, the growing number of adolescents that we are. And we need to address that. We need to learn how to prepare them, to be able to become, good citizens. Mm-hmm. So it's not only in Belize. I think it's important that we make that point that, the fact that this program was developed and is an evidence-based program in Canada is because they too struggle with this similar situation. Yeah. And it's not only in Canada. It has been, it has been rolled out in other countries. In the Caribbean, we have done it in the Bahamas, and then this is Belize is the second country that we are doing it. I also want to add that through the collaboration with PAHO, we are bringing participants from 3 other countries: the Cayman Islands, Jamaica, and Trinidad, so that they can get exposed to this training. Yeah. And then the idea is that for next year we'll be able to roll it out in their countries.
So we have mental health is a key issue for adolescents throughout our region. Unfortunately, suicide is the 3rd leading cause of death in young people in the Americas. And we lose a lot of young people when we look at adolescents 10 to 19 and young people, if we extend it to 24, it's really a major issue, one of the preventable causes of death. Beyond suicide, we have the studies that we have done also illustrate other mental health challenges that our young people have. Some have to do with what we would call disorders, but others are really that young people, the studies show, they struggle with loneliness, with anxiety, with depression, and lack of support in the community. A study we did in 6 Caribbean islands a few years ago, it showed that young people who had at least one meaningful relationship with an adult, be it a parent, a teacher, somebody in the community, was reporting a much lower level of anxiety, of depression, of loneliness. And so mental health has many different facets. It's not just disorders. And when it comes to our young people, we really need to make sure that society knows, is informed, and is able to respond to their needs.
But isn't it, and you know, when we start to have this conversation, especially about teens, I think there are two types of reactions from parents. One is dismissive, and one is absolute fear.
Yes.
Because adolescents by nature are changing so much. They're moody and hormonal and don't understand if they want to act like they're 10 or 20. And it's so hard to decipher when there is a real problem that exists. Can we talk about that a bit more?
So I'm going to ask
Yeah.
Dr. Kutcher to talk about that, but before I want to make sure that there's one of the things that's important for us in mental health is to also have people understand that, and we mentioned that yesterday, that 75% of mental disorders are diagnosed by the age of 25.
Yeah.
50% by the age of 14. So 50%, think about that, 50%. So 75 by the age of 25. So what happened is that we missed this because of not having the literacy that is required to be able to know what is normal, what is abnormal, what is a bad, you would say bad hair day, you know. So we miss that, and in missing that, that's where all the other issues comes in. So I think it will be good to introduce our facilitator for the 3 days, because that's why we want to be able to do this here in terms of, you know, the literacy that is relevant for people to know what to look for then.
See, this has been a fascinating conversation because it's touched on so many different things. And sometimes because when we talk about mental health, we talk about so many different things, it becomes very confusing to everyone. And cutting through the confusion and bringing clarity is really important. So let me just pick up on a couple of those themes. One is growing up is hard.
Yeah.
You know, being a teenager sometimes sucks. You know, sometimes it's wonderful, but sometimes it's terrible. But that's normal. And engaging with the slings and arrows of outrageous fortune is part of how we learn to become competent, responsible, civically engaged adults. So when life is not going well for us, one of the parts about growing up is learning how to deal with that in a positive manner, in a way that you utilize the strengths for yourself and your community and your friends and family to give positive outcomes. That's part of mental health, but so is being able to differentiate the normal negative cognitive behavioral responses we all feel when things go poorly in our environments, to differentiate those from what is a mental disorder, what is a mental illness. And to be able to then not only improve our growth in mental health, but also improve our access to mental health care when we need it, and not when we don't need it. So those are components of mental health literacy. You can't do math if you're not literate in math. You can't speak Spanish if you don't have literacy in Spanish. Same with mental health. You can't understand the multiple complexities of mental health if you're not literate. And we have often jumped to let's do mental health care, let's do mental health promotion, let's do all these different things without realizing that if we're not literate first, we're not very good at doing those things. And when we do them, we're not going to be successful. So we have to start at the foundation. We build a house from the bottom up. And a house is only as solid as its foundation. So mental health literacy becomes the foundation for the other things.
I'm curious because I heard you, Doc, say that there was a empirical approach taken in Canada, and that we've had studies in the Caribbean, 6 other countries, third in this area. But this is a program that's going to be executed in Belize. And so it's a scientific-based program. You have to have some foundation, as you were talking about. What has the specific study about Belize's mental health that has been done? What is the result of that research that is done specifically for Belize, where the program is going to be implemented here?
So yesterday we had, and I don't want to speak for the Minister of Health or the Minister of Health, the Minister of Education and not the Minister of Health, but I think it's important for you to know that yesterday we had a meeting with technical officers from both Ministries of Health and Ministry of Education to look into doing like a situational analysis, understanding what has been done prior to this. Because in order for us, talking about the implementing a project, it's not just training. And I was very pleased that this time you're not just doing it. You know, you come and you want to do a training, and everybody likes to come. And no, this is not just a training. We needed to take time to do a situational analysis to understand what outcomes we want to be looking for, because the outcomes for the Bahamas, the outcomes for Canada will not fit for Belize.
Absolutely.
Because of the differences that we are different. So. So we want to be able to look at what is happening in the country, what indicators we need to select to see if this is going to look at the difference. So the training is Tuesday, Wednesday, Thursday. Then again on Friday, we have another technical meeting to, okay, now that you know the project, bring on board the 2 ministries again and see, okay, on Monday we got together to look at the program, to look at the outcomes. Now let's sit down and then see at what will be how do we implement it? What are the indicators? What are the evaluation plan that we need to have? The referrals, how do we refer and how we have that conversation between Ministry of Health and Ministry of Education. Because refer and return, that was something we need to discuss. How do we do that? And importantly, the issue of stigma also came out of that, because that's the elephant in the room, right?
And that's one of the questions I had for Dr. Kutcher. I watched your TED Talk, and I found it very interesting, several points. But one was talking about how the terminologies we use, which is the basis of literacy skills, is so important, because semantics are really what leads to the stigma that we tend to see. Why is this the case, and how do you change that by a program like this?
Well, you raise a really important point. Language means something. That's why we have it. And if we aren't clear on the words we use, we confuse each other. The other thing is, if we're not clear on the words we use, it means we may not be clear in the way we think. And so clarity of language is fundamental for understanding, but it's also fundamental for communication. So that is actually one of the primary components of this program, is to be really clear about what the language we're using means. So, for example, if a young person has a difficulty in their life, say they fail an examination, or they have a fight with a significant other, boyfriend, girlfriend, whatever, and you ask them, how are you feeling? Oh, I'm depressed. Well, no, you're really not depressed. You may be upset, you may be unhappy, you may be despondent, discouraged, discontented, but you're not depressed. And so when we start using the language of pathology to define normal human emotions, we get into a big problem. So one of the components, and only one of the components of this, is to try to help people understand what language to use to delineate how they're feeling. So there's a difference between having a fight with your parents
Exactly.
and having your dad lose their job. The implications of that emotionally, cognitively, for the family, for you, are very different. And on top of that, if you end up with a depression, that has a different implication. So you have to use the right words to describe the right emotional state.
Yeah, but you know, I suppose you'd agree that there is a wider knowledge of the different mental disorders that exist. For the very same reason that people easily say, oh, I feel depressed, or I have terrible anxiety, or you are OCD, and
How did you know?
I know. I switched it back. I was going into danger territory, and I have ADD, so I can't do that, right?
No, that's me. I have one with ADD.
I was worried about classification. But my point is, so it becomes a part of general conversations, which one might believe is a good thing. We're openly talking about conditions. But what is the danger that comes with that?
Well, there's a difference between knowing about something and knowing something.
Okay.
So I know about electricity, but you do not want me to put an electrical panel in your house. I will tell you that right now. Forget it, okay? And the same thing with the mental health area.
Yeah.
And you raise an important concern. When we don't know what we're talking about, it's easy to get ourselves confused. It's easy to get other people confused. And it does two things. One, it trivializes the illness. So when I feel unhappy and I call that depression, or if I feel nervous and call that anxiety, or if I'm very good and particular about my work, so I'm going to be a good dentist, and I call that OCD, then that trivializes the illness. Okay? But the other thing that it does is then it causes people not to seek help when they need it, because they don't understand what's the difference between now I have an illness and I need the care from, oh, I'm just this way. And that's not good.
And in the context of the classroom, it might be that they classify a child as being disruptive, causing problems, while that child might really need other support, additional support. And so I think that this program, the reason why I really like it is it engages teachers. And I think it will also help teachers with their own issues. And at the same time, be better support young people, because young people today, they do have a lot of information, but it might not be the right information because there's access to internet. I'm also a mother of an adolescent, and so I'm very familiar with self-diagnosis. Oh, I'm depressed. Oh, I'm this or I'm that, because they can Google something. But having accurate information is so important for the young people and for those who are responsible for their care.
I want to pick up though on what Kevin was asking in terms of the two ministries, because I think it's relevant that we know that the Ministry of Education is now on board, is now working on the curriculum. So it was just interesting, they did a presentation to us because they realized their challenges. And their challenges in terms of life skills, and the challenge that you have, you need to have teachers who are competent to be able to teach this. So then the Ministry of Health, the mental health program, also did a presentation on their, prevalences on disorder, on management, on the structure, on the issues, on the challenges with suicide, and now they're in the process of developing a suicide prevention plan. So both, what we wanted is for them to come to the table, right? And then present, these are our challenges, and this is what we are doing to be able to address that. So I don't know if that responds to your concern.
I
think
want
it's
to
relevant.
know a little bit more about the cognitive map. What structure do you see it possibly taking this program? What is the structure? Is there going to be a manual afterwards? Is there going to be a structure in terms of, because I would assume that mental health is just like physical health. You have primary, secondary, and tertiary level care. So a teacher in a classroom can be given certain tools, know what specific words to identify the problem that they're facing. But if the problem is deeper, then they refer to a counselor. And the problem is deeper, then they refer to a psychologist. And we know the capacity problem that we have in Belize in terms of the number of psychiatrists that we have. But my question is, what is the structure that this program would take?
We want to look at the expert. That's why the expert is here. More importantly is that we don't want it to be diagnosing mentally. That's not what they're there. You know, they're there to teach, but precisely to be literate in what they're teaching. So I think this is.
There are two responses to your important question. One is, what is the structural components as they will roll out in Belize, which I think you were getting at, and I can't answer that question because that's not what we're doing, what I'm doing. So what I'm doing is bringing tools that have best available evidence from 20 different countries that show that when you apply the tools in the context of the country's needs and the context of the country's capability and capacities, you improve the capacity to enhance mental health outcomes for young people. The program only works if it is applied in a way that makes sense to the country. Okay, it's not prescriptive, it's supportive. So here are the tools. We'll share with you what we know about the tools, we'll share with you and help you develop your competencies. How you then apply that cornucopia will be dependent on what you want to do, how you want to get there, and where you want to end up. Now, what I was very pleased with is having both the Ministry of Education and the Ministry of Health, with PAHO, and UNICEF was there, to start to discuss how they could do those things. So the program, I was seeing it as a catalyst for having the conversation, how can we work together to make this better? Because, you know, in our systems, and this is a commonality around the world, parents have given permission to both institutions of education and institutions of health to help raise their children. Right? They've given that permission. Whether they've realized it or not, they have given that permission. So it is incumbent upon both health and education to work together and to engage with families and young people to fulfill those obligations.
When we talk about this is a program that you're hoping to implement in the secondary schools. And if we talk about our own development in Belize in the conversation of mental health in secondary schools, when I was there, it was just a nice teacher that was your counselor. You just go to her if you were giving trouble, looking sad, you know. She was nice. That was the important part.
Yeah, it's a start.
And but now we've developed into where there's a school counselor program for secondary schools, and most secondary schools have a counselor. I believe that's what we've been told by the Ministry of Education. My question is, though, oftentimes it's kind of a one-man program, one-woman program, and there's what the teachers do and there's what the counselors do, and there's a separation of work that they're attempting to do. But you need the buy-in of the other teachers. You know, if a child has a challenge in any way, maybe they are going through a really rough patch and is going through a bout of depression, or they're struggling with anxiety, diagnosed, and you don't have the teachers buy-in in the classroom. And because mental illness just doesn't look like a broken leg or a sprained ankle or a cut on your forehead, other teachers just say, well, I don't know what the counselor's talking about. That kid looks normal to me. He's just not trying hard enough. That connection just within the school system can cause problems, that disconnection can cause problems as well. So how do you ensure, you sigh, I don't know if it's because I hit a point or because...
You really hit a point, because you know, that teacher, if the child has a broken leg, she will not say, don't take him to the hospital, right? If the child has a broken leg, guaranteed the teacher is going to call the parents and say, you know what, he can't walk. But regardless, he's going to the hospital. We're taking him to the hospital. Actually, he's going to go, right? So it's not questionable. But then when it's mental health, it is questionable precisely because we don't know what we're talking about. Now, on one hand, you had one counselor for, what's the largest high school here?
Maybe
probably
300 to 500.
Exactly,
Yeah.
one counselor. So she doesn't spend the number of hours that the teacher does with the kid. So the teacher gets to know this child better than the school counselor when you think about that, because of the time that they spend together. But then the teacher needs to know what to look for, needs to know what to report on. So they need to have that. So when I was explaining this collaboration for us, right? Remember I mentioned that we work in the same organization, but I have my department and then Dr. Caffe has her department. But we need to get together in order for us to understand that if we want to do something for adolescent mental health, so PAHO, for us at PAHO, that's very important. And we bring the expert on board. And then and it was interesting yesterday that when we were talking about the context of Belize, there was a question in terms of how do we do the rollout? We're learning the tool, this is the tool, who's going to do this training? And I like what you said, so with your permission, I will repeat it. You know, if you're going to be training, if a doctor is training doctors, right? If a nurse trains nurses, they will listen to the nurse. If a teacher is training a teacher, they're going to listen to the teacher. Most likely you listen to your own peer, right? Yeah. So we bring them two together so that the training is by health and by education. But you need to have the teacher to be able to get on, you know, to know what to look for, to understand that map, because without that, they'll get lost again. So
how does this not become overwhelming? If I were a teacher listening to this, I'm thinking, yes,
another job.
Another job, and a job that I really, you guys studied for how many years to understand this particularly? How does a teacher not become paralyzed to say, listen, I realize that this child, like I was, dyslexic, you know, what does that mean? You know, I don't have the time to do that. I have to do my school training. There's another child behind there who's physically sick. There's another child there. I have my own issues. How does a teacher not become overwhelmed?
Okay.
And what tools, I wanted you to please unpack a little bit more as to these tools that you're going to leave with these teachers.
Perfect. You're exactly right. And we keep demanding more and more of our teachers without changing the structures of the systems. But that's a conversation for another day. In Canada, we still have the exact same school structure that we had in 1847. Not good, because times have changed. But we'll deal with that another time.
We're really no different.
No,
So.
okay. And teachers do an incredible job with the resources that they have and the challenges that they face. So one of the things about this intervention is that it's predicated and built on what teachers already do. So we're not asking teachers to take in a program. We're not asking teachers to become counselors. We are providing them with classroom plans. Here are the 6 classroom plans that are the mental health literacy components. And they learn how to apply the classroom lesson plan in their own classroom. That's what they're trained to do. They learn how to do it. And when they learn how to do it, they teach it their own way. And the results are astonishing. It's so simple, I'm embarrassed by it. But it works so well because it's what the teachers are already teaching. In the curriculum revisions that we saw for Belize, which look fantastic, all those components of what they're supposed to teach are already there.
Teachers were asking.
The problem is that when you don't give them the tools, then they become completely overwhelmed. But once you give them the tools, then they're not so overwhelmed. It's the same thing like when you train a surgeon. If you just put you or me in an operating room and say, go do it, but if you give them the training first.
But my concern is from a different angle with the teachers, and you're right. They are, you know, many of our teachers have sacrificed so much to be in the classroom, from the pay that they get to the time that they put into the stresses that and health issues that they face as a result as well. But there's a very common saying that hurt people can hurt people. And we're a new generation where we talk about these issues, but many of our teachers were not a part of that generation and may very well be people who are struggling with an illness, a mental illness themselves, whether it is some sort of severe trauma or it could be whatever. How do you equip teachers who've had no foundation in understanding their own mental health to then pass it on to children?
And then this is one of the amazing things about this intervention. We actually have shown with studies in many different places that when the teachers engage with this approach, they learn the material in order to be able to teach it. when we measure their own mental health, it improves. And not only that, the mental health of their families improves. And they start to identify, self-identify, peer identify, and family identify those people who need additional help and act on it. So we have not just vertical transmission, but we have horizontal transmission as well. So, you know, it's really quite neat.
Neat is a very talking of language there.
And that helps to decrease the stigma in terms of seeking help too. That's very interesting. But I wanted to add to what you're saying, the challenges for teachers, because it's not only mental health, right? I'm sure you guys interview people coming from HIV/AIDS, people coming from every program is very important.
Yeah.
Every program is very important. And who's going to implement that? Probably the teachers.
Yeah.
The same thing happened to us when we talk about in the health sector, that you want your primary care, the first level of care, you want them to learn as many as possible things like mental health too. And then you get the people from heart cardiovascular disorder, they want them to learn about cardiovascular, and you have each one comes with their own little book. That is very important. But what we're doing here is to provide them the tool to make their life much easier, because I also use myself about this, like I wear glasses because after a certain age, as we all know, we can see certain distance, right? So if you put me to read what you have there, I can't do that without my glasses. So I need my glasses to be able to make sense of what I'm going to be reading. So the tools is to help people to build that competency, to be able to make sense of what they're looking at.
Now,
Because we can't give you all the 7-9 models.
But you can go online and look at it yourself.
Well, I wanted to hear from you
We could do
firsthand
that.
the research that was conducted.
Sure.
And because sometimes it's important to help us understand why the tools are important. Perhaps if we understand what happens if we don't have that tool, what the implications can be. So there was a research done in being able to look at mental health programs for young people across the world. And also you did a clinical study as well with two different groups. Tell us what you found in the difference between when a young person is equipped with this type of literacy versus those who aren't.
Okay, a number of things come out of the studies, and they are in multiple countries, and it doesn't matter which country it's done in, the results are very similar. So we have comfort that this intervention is going to be helpful. So the three things that really come out very strongly is, number one, knowledge improves dramatically, and it stays improved over a long period of time. So the longest that we've been able to study forward of the intervention is 1 year. But there's nothing in education or health that takes what you've done in one time and sees what a year later is. And so huge improvement. But this is not just for students, but for teachers as well. Okay? So huge improvements in knowledge. Really substantive decrease in stigma in all aspects of stigma, and it stays improved, and improvement in help-seeking efficacy, knowing when to get help, when not to get help, and giving competencies for people so that when they do get help, they're more likely to get good help, and their actual help-seeking itself changes. So those things that mental health literacy can do, it can't do everything, okay? Those things that it can do, it does with this intervention.
Now, how about tapping into the tools that young people love? We know, and you said it for yourself, they're online.
Yes.
They want to do everything on their phones, and there's the serious, I'll do the generalized classification. There's some kind of separation anxiety that they get without it. But, we struggle, my generation alone struggles in understanding what my teenage nephew, the relationship he has with his phone and how he uses that to connect with other people. And so when you're in a classroom and when you actually have that one-on-one interaction, I always question whether or not it is as effective or using the ways they have been connecting. So how integrated is it with the language that young people talk today?
Oh, very much. Remember that the phones are a tool, and that what we are dealing with as every society that is being introduced to this new technology is we don't know how to use it to improve our lives yet, and we haven't figured out what the risk to benefit ratio of the technology is. When the automobile came, we were in the same situation. But when the automobile came, we had no specific roads, we had no traffic signs, we had no lights, we had no licenses, we had nothing. But we learned how to do that, to harness the technology. And we are right now in the earliest phases of learning how to harness this technology so it will have more benefits than negative outcomes. Every technology has both. So our challenge is not to just say, oh, wonderful, because kids are using this, so we have to use it exactly like the kids are using it. No, 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 our challenge, we're adults. Our challenge is to, how do we understand to use this technology responsibly so that it helps kids grow and develop to become successful, contributing members of civil society. Okay? So we don't just go, oh, good, kids, technology, wonderful, let's just do it. All that is shiny and new is not necessarily good. So we have to engage young people, but we also have to remember we have to keep an open mind, but not so open that our brains fall out. So we have to just work collaboratively and figure this stuff out.
And from a PAHO perspective, this is why this collaboration is so important, because we see the adolescent as a person. Mental health, physical health, protective factors, risk factors, substance use, all these things together help either support a young person to develop in a positive way or puts them at risk for premature death in the worst case scenario, or let's say suboptimal development. And so this collaboration fits in a comprehensive adolescent health perspective, and I'm really happy to also note that the Ministry of Health is working on a new adolescent health plan of action where this becomes part of it. And in the whole regional approach, working with digital platforms is very important, because we know, as Stan was saying, that young people live in the digital world, and it has its benefits, it has really its risks. Not only with bullying and those types of things, but also what does it do with the brain of this young person, the long term, and so we really see this as part of the puzzle to help young people to develop in a healthy way.
My final question I want to split in two, if I can. Placement is important, I would assume, in terms of placement is important, where you apply this program.
Okay, yeah.
And so in placement, I have two questions. The first is, a child doesn't automatically become an adolescent. And so the process that they go through before and experience that they have before becoming an adolescent are important. I think they were saying that by 8 you already have developed major personalities and that
St.
sort
Paul
of thing.
said it was by age 3.
Yeah.
So even more so. So if we completely damage your kids all the way up, and then we're just trying to fix it at adolescence, we're giving ourselves a lot of work. So in terms of placement, why is the program specifically to adolescents, and what mechanism is there for getting the younger ones so that we have less of a problem when they get to adolescence, when they're already dealing with other issues?
Prevention versus intervention? That's
Yes. So even when we're intervening, we have less work intervening because we've already done some structural work with them before. That's the first question.
Can I answer that very quickly?
Oh, go ahead.
Yeah.
Sure. You can't eat a cake all at one bite,
Yeah.
right?
Yeah.
It's not possible. So you have to start biting off what you can chew and what you can do well. I'm not saying that the early stuff, it's essential, but it's not on my mandate. My mandate is for adolescent mental health. So I have to do what I can do as best as I can do it, realizing it's not the whole answer. And so why adolescence? Because of two reasons. One is that is the time in the lifespan when major mental disorders can be seen for the first time: depression, substance abuse, schizophrenia, obsessive compulsive disorder, eating disorders. So that's the period of time we see them. So it's essential that kids know about them at the beginning. The second thing is, during adolescence is the point in time where the life, and so you know more about this than I do, but where the life skills for health improving behavior become solidified. They don't start, but they become solidified in adolescence with the identity of the adolescent peer group, with the understanding of what it means to become an adult and take on the responsibilities of adulthood. So it is at that point in adolescence where we have to try to intervene to help young people develop the health maintaining components of their life that they need to develop. So that's why in adolescence.
Yeah, I just wanted to add that there's different programs. We call it a life course perspective, where we look at what are the interventions that are essential in each life stage to build a positive life course, a healthy life course. And there are programs that look at early childhood development, that is also that includes motoric development, physical development, development of connections, loving connections. And so there's other interventions that actually do target the earlier years of life.
I appreciate
From
that.
birth to-
I appreciate that answer, because that kind of quells what my concern was. The other aspect
From
of
birth to
Pre-birth.
Yes, yes.
life course approach.
Life
yeah.
course
From
approach,
womb to
yes.
Womb to two.
from
And-
womb to
and the second and final part of the question is, I mean, in terms of teachers there's a spectrum of teachers. The ones that are just training, the ones that are currently in the profession. How do we touch each of them to get optimal returns?
Did you pay this guy?
Yeah, that was the question yesterday.
Well, we have actually realized exactly what you realized.
Exactly that. Yeah.
And about 5 years ago, we did a survey of all the faculties of education in Canada to find out, of the 72 faculties, how many of them were teaching mental health literacy to the pre-service candidates. Huh? 0. And yet when the teachers come into the classroom, well, what do they face? Mental health challenges with young people. So we worked together with 3 different universities and created, for the first time ever globally, a complete online training program for pre-service teachers. We're making that available here as well. The price point is, you ready for it?
0.
Free.
I like that price point.
We had the same question yesterday from the Ministry of Education. When they were
Sorry.
saying, we had the same question from the Ministry of Education, where they will go to a high school, right? And then they do some training with the teachers, then come back again, and there's new teachers. So they have to continue.
Yeah.
So we were to explain to them how you have tools to be able to evaluate their competencies.
Yeah.
So every time you come, you have the tools to evaluate if this teacher is competent to be able to do mental health. Easy. So even if I come, I will to teach whatever I'm going to be teaching. If it's teaching nutrition, for example, but now I want to teach mental health, the principal should be able to ask me, hey, we have this questionnaire here, how we determine if you're really competent to do this, take this course. So I think that's relevant.
Not because he's here, but I just wanted to say I really love this program because it's so. Yeah, not because Stanley's here. It's because it is evidence-based. They looked at how does this work, what do we add, and it really looked at sustainability in a low-cost environment. And I think that's important because sometimes we come and we have a wonderful program, but it's not sustainable, not scalable. But this one is.
Well, for PAHO, it's very important that we partner with people who, and we know each other for over 15 years.
He's trying to stop me from saying the years and stuff.
I wanted to add something quickly, if I can.
Yeah.
In terms of the what I like about the program too is that there's a section there, because we always talk about the teacher, the students, and when you were talking about the apps or the technology, media plays an important role.
Yeah.
How media reports mental illness, mental disorders, how media reports suicide, for example. That is not a very responsible manner. So there is a section in the there's a module that helps them to seek, for example, celebrities that have mental illness and how they have been reported and how that happens in your setting, in your context. So there's a homework they have to do for their own context. Of course, you send them to do, So it's very interactive in that manner. And I think it also touches on the relevance of the role of the media. So I think that's...
I'm so glad you touched on context, because we really can't leave without talking, and I'm sorry, but you know, there's the local context is important. Our children are facing a number of problems, and some is evidence-based and some is just anecdotal. We know the poverty that affects children. We know the physical and sexual abuse that's affecting our children. We know the level of gang violence and violence in our country that children are exposed to. And in fact, I believe we had mental health professionals coming on one time to talk about children having post-traumatic stress at the level of soldiers at war because of the amount of dead bodies, murdered family members. When you talk about a program that was inculcated in Canada, many will look at it and say, listen, that can't begin to cover the challenges that our 13-year-old male boys in an urban setting is facing. How would you respond to
I
that?
would say you're absolutely right. But the program is not just in Canada, it's in Malawi, it's in Tanzania, it's in Guatemala, it's in Finland, it's in Portugal, it's in Romania, it's in the Bahamas, it's, you know, it's in China. But you can't expect what we're doing here to solve all those other problems. It's just not possible, and we're not saying it does. Poverty is a humongous problem, and it takes a lot of effort to fix poverty. Gang violence is a humongous problem. It takes a lot of effort to fix gang violence. We have to do those things. Literacy is not difficult to fix. All right? So I'm not saying to do this instead of doing that. Yeah, we need to do that. It's hard work. Every single country in the world has those problems, and we're not very good at fixing them, right? But literacy we can fix. We know how to fix literacy. So while we're still working on those problems, which are essential problems to fix, don't forget that we can do the literacy very frugally, very easily, and that's going to also be helpful to people. It's not going to fix poverty, but it'll help.
Last question, and I know we're totally out of time. For the parents who are watching, who want to do better for their adolescents, who want to help with improving their literacy, what are some real practical tips, advice that you can give to them that today they can do differently as they're driving their teen to school or picking them up after school?
As a mother and as the adolescent health advisor, and I'm sure you also can add to that answer, is listen to your kids. It's really listening to them, because as you mentioned in the beginning, the first thing you're like, oh my goodness, another adolescent issue here. But listen to your kids, you know, and educate yourself, because this program, it targets teachers and health workers, but parents need to have that literacy as well. So educate yourself and listen to your kids.
I would agree. Listen to your kids is essential. Respect your children, but don't forget you're their parent. Part of the job of a parent is to guide young people in a respectful manner. All right. So, and there is no manual for parenting. All right.
We just had one.
Yeah.
Literally, just had one.
There's no manual for parenting. Okay. And parenting is difficult. And if you are a parent that has more than one child, you don't parent those two children exactly the same way, because you have to adjust your parenting styles to the needs of your child.
So to add to that, I think relationship is very important, that you build a good relationship with your child. And that doesn't start when they're adolescents.
Exactly.
That starts when, you know, when you have, talking about the life course, from the womb, you know, to, you know, when they become toddlers, infants. So through that, I think you build that relationship, that bond with them. And so by the time, you can't, if you have a good relationship, or a healthy relationship, because, you know, good can be, but you build a healthy relationship with your child. As a parent, I think that's definitely very important.
Thank you for coming in. Thank you for telling the details of what you're embarking on, and best of luck.
Thank you.
Thank you.
Thank you very much.
We're going to go ahead and take a break, and when we come back, we'll be focusing on tourism as the Belize Hotel Association prepares for its upcoming biannual meeting. So stay tuned.